So what's the purpose of PACE? PACE provides prepaid, capitated, comprehensive healthcare services, and they're really designed to enhance the quality of life for frail older adults and their choice and their ability to live in the community. They're designed to maximize the dignity and respect for older adults and enable our frail older adults to live in the community as long as possible. We really have some foundational ideas and philosophies about supporting our older adults to continue to live in the community and as part of their own family unit in that community. So who does PACE serve? PACE serves individuals who are 55 and older and meet a nursing facility level of care. The average PACE participant often has multiple conditions, diagnoses, cognitive, functional impairments, and significant long-term care needs. PACE participants also have to live in a designated setting, and we'll talk a lot about this a little later in the presentations. And finally, PACE participants must be able to live safely in the community with PACE services at the time of enrollment. I used to, here, I'm not anymore, but I used to be the waiver guy at the Department of Community Health for many years. I was over the home and community-based services. And people would often say to me, well, you're all about people living in the community, which was honestly true. But there is a time and a place for the safety of an individual where they may need nursing facility services or they may need hospital services. So we're not saying that when we talk about PACE that everybody should be in the community, but if participants are able to live safely in the community with the PACE services at the time of enrollment, that's what we want to foster through the PACE program. What is the PACE model of care? The PACE model of care is care that is coordinated by an interdisciplinary team. It's typically a 11-member interdisciplinary team that does the assessment, develops the plan of care, and coordinates the delivery of that care 24 hours a day, 7 days a week as medically necessary. The PACE program does not only medical, but health and social services, and it's an integrated service where it's primary care, acute care, and long-term care. The place of service may be done at the PACE Center, maybe a clinic at the PACE Center, or they may come in for therapies for the PACE Center, but those services can be delivered at home and in the community as well. Maybe personal support services need to be delivered to the individual's home or some other service to keep them healthy and safe in the community. Participants are provided transportation to and from the home, the PACE Center, and any other services that they may need. So if the member needs to go to a doctor or they need to go get a test done, then that PACE Center is also responsible for coordinating transportation for that member. So we always try and say what services are covered under PACE. When we first started talking about this, we were going to a lot of the association meetings, and being the waiver guy, I was getting a lot of, hey, we can do this. I work in the waivers and we can provide all the waiver services. And I was really having to communicate to our waiver providers, that's great, but PACE is more than just your waiver services. They have to be able to deliver all Medicare and Medicaid services. And we've listed a bunch of those out here that are included, including things like dentistry and prescription drugs. So it's all services that the interdisciplinary team determines through their assessment and their plan of care that that individual needs to receive. But what services are required? So we're just re-emphasizing this here, just so it's crystal clear. It's all services. It's everything that the member needs as covered by Medicare, Medicaid, and other services that the interdisciplinary team determines in order to improve and maintain the overall participant's health. So who is on a PACE interdisciplinary team? Professionals and paraprofessional staff. They do those things we talked about, developing the plan of care, doing the assessment, and delivering services. They are acute care services, nursing facility services. Typically what we see is a dietitian, a driver, home care liaison, nurse, occupational therapist, PACE center supervisor, personal care attendants, physical therapist, primary care physician, recreational therapist or an activity coordinator, and a social worker making up that interdisciplinary team. What are the responsibilities of the interdisciplinary team? That initial entry assessment along with periodic assessments of the individual participant at the PACE Center. Anytime when you're working in one of these programs, you want to make sure that your plan of care is actually progressing appropriately. So that's where you have those periodic assessments to make sure you're delivering the right care and you don't need to add things, remove things, get different services in. Planning care for each participant, coordinating their care 24 hours a day, 7 days a week, processing service determination requests, and then individually for each member, the interdisciplinary team should be informing the team, the individual team members, of medical, functional, and psychosocial conditions of each participant, remaining alert to any information they're not only getting from the member, but they may be getting from the family or other people at the PACE Center if they're coming in for day treatment about how that plan of care is progressing. Documenting the changes in the participant's condition and being the primary source of healthcare needs for that PACE participant. So why are we looking at incorporating the PACE service design into the Medicaid plan? We know that for almost 50 years now, there's a history of PACE. Dozens of research articles have been written on PACE, and the results of these studies are really clear that it provides quality and cost-effective community-based care to older adults. And these older adults would otherwise be in an institution and not at home and in our communities. It's good consumer and family member satisfaction. People really like PACE. Like whenever you go to a PACE center or talk to people about PACE, PACE is very well regarded for those people who know the PACE program. Again, it reduces the use of institutional care and it gives better overall service utilization by PACE members. PACE members are much more likely to access the services they need. So we just have some information on that kind of bolsters that from a few states. This is a satisfaction rate survey and information from Rhode Island, where you can see that 93% of PACE participants rated their care favorably. That's a really high number for, especially in Medicaid and the services we deliver. 72% of PACE participants enrolled for at least a year. And as I said, this is an optional program. So they can have the choice to leave the PACE program at any time if they choose. Over 4 years, greater than 4 years, participants were kept out of nursing homes when you compare them to a similarly situated population. And 11% fewer visits to the ER made by PACE participants, again, for similar recipients. We have more information from New York. Again, 24% lower hospitalization rate for PACE members. 95% of the PACE members live in the community instead of living in a nursing home who are participating. 96% of family members reported being satisfied with PACE support. That is far greater than what we typically see in other areas in Medicaid. And 97.5% of caregivers recommend the PACE program when asked. So what did we do? First, one of the first activities we did is we did a DCH assessment of PACE. During the 2023 legislative session in 2024, House Bill 1078 permitted DCH to establish and implement a PACE program in Georgia. It was passed and signed by the governor. So DCH staff conducted and met with the National PACE Association and asked them to look at the viability for our PACE program in certain areas of the state. Fulton, DeKalb, Chatham, and Bibb initially. We also met with interested providers, and we even had one provider that had already completed their own assessment of viability for these same counties and other metro Atlanta counties. We met with representatives from North and South Carolina. We looked at estimates of potential members that could be served, and we reviewed the potential number of new nursing facility entrants versus PACE eligibility to see how many members might be able in that PACE population that would overlap with nursing home entrants. And we found that it typically runs between 10 and 15% of those eligible opt to enroll. We then contacted Myers and Stauffer, who I introduced a little bit earlier, and developed 6 regions for the initial PACE RFP. Additionally, we were able to, thanks to Governor Kemp, signed by Governor Kemp and the legislature, we were given some funding, $2 million in total, to do some grants for nonprofit PACE providers for PACE development. I was able to be on that RFP committee, and we were able to award 3 grants of $500,000 based on the submissions we got for the grant. So we also had some seed money for some nonprofit agencies that were able to utilize that funding in order to develop their PACE programs. I'm going to pause here and turn it over to Joe to talk about draft and preliminary rates.
Thank you, Brian. My name is Joe Hood. As Brian said, I'm the Chief Operating Officer for the Department of Community Health. Thank you for being with us here today. I did want to state this presentation will be posted at the conclusion, and it'll be available to the public and to interested parties. So all the information here you'll be able to see in detail after the fact. And I also believe we have a recording, and that will also make this available to those who may be interested. So what I'm going to talk about is the draft and preliminary PACE rates that will be established and how that comes about. Under a PACE program agreement, the state administrating agency makes a prospective monthly payment to PACE organizations of a capitation amount for each Medicaid participant. In that instance, the SAA, or the state administrative agency, is the state of Georgia, Georgia Department of Community Health. The monthly capitation amount is set by DCH and is less than the amount that would otherwise have been paid under the state plan if the participants were not enrolled under the PACE program. And it takes into account the comprehensive medical needs of the elderly when developing the overall capitation rate. It's a fixed amount regardless of changes in the participant's health status, and it's updated annually. For those who are familiar with the care management organization, the department has a number of care management organizations that we contract with for Medicaid enrollment. And we have an actuary that sets a per member per month rate for those folks who are enrolled in a CMO, as we call it. And this is the same similar process that's establishing a per member per month rate for PACE enrollees for the provider to receive. The PACE organization has to accept the capitation payment amount as payment in full for Medicaid participants. So, this is very important because some folks might understand that in Georgia, in a typical CMO and other fee-for-service environment, we would, for example, have non-emergency medical transport as an independent contract, or pharmacy or other things that are independently contracted. That's not the case here with PACE. Everything is contained and expected to be fulfilled within that amount that you're receiving, that the provider is receiving on a per member per month basis. For dual eligible participants, the PACE organization will receive a capitation payment for the Medicaid portion and the Medicare portion, i.e. 2 payments that combined to cover the full cost of care for the enrollee. And we do expect that that would be a large majority of those who would initiate and be served, although we may have some Medicaid-only participants as well. So the PACE amounts that would have otherwise been paid, or AWOP, we didn't make that up. That's actually what they call this designation. I think it's very clarifying and transparent, right? So it's the amount the state would otherwise have been paying for these members. So we had our actuary go through, we contracted with Deloitte, who is our actuary for the department for CMOs and for all our actuarial studies. And they looked at the most recent statewide claims data and enrollment information for the state's nursing home certifiable population. So that would, as Brian talked about, include home and community-based service waiver population that are at a nursing level of care. And then it also includes our nursing level population that is in a skilled level setting and is being served by nursing homes. So it has the claims information from both those populations and is the certifiable population. The PACE comparable population is identified by limiting claims and payments to members who are at least 55 years old, and then doing the comparable population composes the base data. The PACE AWOPs are then developed by the rating cohort based upon the appropriate service regions and dual status. So you'll see this a little bit later in the slide. We have our regions established, and it does vary by region depending upon what the actuarial claims data shows on that basis. And what we've done is we've matched it to our care management organization regions for rate setting, so it's consistent with what we're doing there from the actuarial standpoint. The data adjustments were made to arrive at the projected AWOPs to include but not limited to the following: incurred but not reported claims, nursing facility reimbursement adjustments, prospective trend of claims and medical needs, any other program or fee schedule changes, patient liability, administrative loading, regional adjustments, and then nursing home and home community-based service settings of care distribution assumptions. The payment rates will be paid by service region and dual status, adjusted to remove patient liability by member and discounted from the AWOP based upon the methodology set by the Department of Community Health. The Department of Community Health establishes the Medicaid capitation rates at a percentage of the calculated amount that we would otherwise paid, and they'll be updated annually. So the amounts that we're going to show next, I want to be clear, are preliminary draft rates that were prepared by our actuary, and they're our best estimate given all the factors that I've gone over. However, we will set the actual rate at the point in time of when a provider enrolls, which may be at different points in time throughout. Generally, we set actuarial rates for a CMO at the beginning of our state fiscal year. So it would probably most likely be in concert with that to the extent we can. But just to emphasize, these are draft preliminary and they'll have to be updated for all the things that happen between now and the time in which a provider actually enrolls. So with that, the purpose of the RFP, the following draft and preliminary rates are set at 97% of the amount that we would otherwise pay per month and have been calculated as identified below. And I'm not going to read through these, but these are the areas that we anticipate that we're going to have in our request for proposal initially. And that you can see that's why we have them set forward for Atlanta, Central, Atlanta again, and then Central and Southeast. And then we have them for Medicaid only, and then we have them for dual eligible. So the rate will differ depending upon if the member is dual eligible or if they're a Medicaid only member. The above are Medicaid rates for RFP purposes only. The rates will be determined as a part of the PACE application and site approval process. And on the next slide, we're going to talk about information regarding the draft and preliminary rate formation. So these are our notes about the formation. The draft and preliminary 2025 PACE rates in this presentation are for RFP purposes only and subject to review and revision. Prior to implementation, the AWOP per member per month, nursing home, home community-based service blending assumptions, and other rate considerations are subject to review and revision as DCH determines appropriate to reflect the anticipated contract period. Let me pause there and explain that notation. So the actuary had asked us how we wanted, what assumptions we wanted to make in this, and did we want to include nursing home assumptions from the very beginning, and the state has chosen to do that. So they've actuarially determined how many folks of a population would eventually be in a nursing home, and they factored a higher cost ratio to account for that. So you would have, a number at some point in time that unfortunately may have to go to a nursing home. When we visited the National PACE Association and we did site review, that was one of the questions I asked, and it was a small percentage, but almost every one of them had some percentage that was in nursing home care at some point in time. So that's why we felt it's important to encapsulate that in the rate from the very beginning and have it. So this is a blended rate that has all the component parts, including the projection that, a percentage will ultimately be in nursing home care. The rates shown in the exhibit are inclusive of estimated medical and administrative costs and of patient liability. Rates shown in the exhibit include the estimated Medicaid portion of members' cost only and do not include estimated Medicare cost for the PACE and dual eligible members, which are determined separately by Medicare. Payment rates will be paid by service region and dual status, adjusted to remove patient liability and discounted for the AWOP based upon the methodology set forward by DCH. So that concludes the overview of the rate setting and gives you an estimated rate that you can refer back to when this document's available. And then what we're going to do next is talk about the anticipated PACE procurement and timelines about how we'll proceed. I'm going to turn that back over to Brian.
Thanks, Joe. So this is our anticipated timeline for procurement, and most people want to go, well, where are we on the timeline? So I'm going to skip forward to that point because we talked about how we did the conduct a market survey study, determined our draft regions. Joe just talked about the establishing initial draft capitation rates as well. So the next thing we're in the process of doing right now is a state plan amendment to the Medicaid state plan to allow us to be able to deliver PACE services. Yesterday, I presented for initial adoption at the DCH board meeting that state plan amendment. So that typically we have an initial adoption from the board. We have a public hearing. You have a period of time to send in the public comments if you have any. And then in December, it will go in front of the board where we summarize any comments we receive, make any adjustments based on those comments, and then ask the board for final adoption. Assuming it is adopted in December, that gives us the ability to move forward with a state plan amendment to the Centers for Medicare and Medicaid Services. So we are at the town hall meeting right now to engage stakeholders. So you're on the timeline. Congratulations. Next, we will be conducting our procurement activities and awarding PACE centers. So next step, RFP, right? That's where we are because we're in the middle of that board process. So that is what our big next step will do. We plan to issue a request for proposal for the purpose of selecting qualified suppliers, and they're going to be based on service regions that are established by zip code, and we'll show you those in just a few minutes. The first round, we will have 6 regions of Georgia and a potential for a special health-focused service area. Each selected supplier will then be permitted to proceed with the application stage with the Centers for Medicare and Medicaid Services. And approved applicants will enter into a 3-way program agreement to become a PACE center in Georgia. So again, a PACE center must operate at least one PACE center as defined by its service region, and it must assure accessible and adequate services to those members that choose to enroll in that service region. The frequency of attendance at a center can be determined by that interdisciplinary team and based on the assessment and plan of care for that member. So that this is, again, all those things that the PACE Center would be providing in a visual format. What are some of the PACE organizational requirements? They must complete an intensive application process with the Centers for Medicare and Medicaid Services. And they also have to undergo a state readiness review before we allow participants to be enrolled. It can be the PACE organization could be nonprofit, private, or public entity that is primarily engaged in coordinating and providing all PACE healthcare services. You got to have a governing board that includes community representation. You have to have a physical site, right? Because it's a center. So you have to have at least a 10,000 square feet or approximately a 10,000 square feet center. And that typically surrounds that adult day health center with other services. We'll talk about the defined service areas in just a minute. You have to provide that complete service package. You also have to have safeguards against conflict of interest if your organization has other similar lines of business. And you have to demonstrate fiscal soundness. So what does an organizational structure look like? Typically starts at the top with a program director who does oversight and administration, and a medical director that does participant care, clinical outcomes, and quality improvement projects. So we want to talk a little bit now about our draft service regions that will come out of our first round of RFPs. And I want to just take a pause here to say we do anticipate additional rounds of RFPs after the initial RFP set. So this is the initial service areas in the first rounds of requests for proposals for PACE. I'm going to start with Alpharetta and the zip codes that are associated with the Alpharetta region. It's Alpharetta kind of is the center, but it goes into Roswell, Duluth, Milton. Why did I call it Minton? Milton, I actually grew up here, y'all. I can't believe I just called it Minton. Milton, and then up to like the Coal Mountain zip codes as well. So that's the Alpharetta region. Because we often say, when we were even going through this process, we would say Decatur. And for those of us who live in Decatur, we were like, yeah, it's Decatur, but it's also some other areas. I would not call Clarkston Decatur. So you kind of really have to focus on the zip codes. Next is Columbus, which goes all the way, up to West Point and over to Pine Mountain and down to the Columbus region. And again, I want to let you guys know we will have these slides available, so you'll have access to this information. The next draft service region is the one I was just talking about, Decatur, over to Clarkston, Belvedere Park, down to Gresham Park. So it's a big swath of kind of the East Atlanta, Decatur area. And then there's East Point and College Park. So there's quite a few zip codes here that pull up into Atlanta, down to East Point, down to College Park, and then even down to Taylor Crossing. The Macon region, which surrounds not only Macon, but also into Warner Robins. And somewhat a little north of Macon. For those of y'all who know Macon, there's a lot of service areas and neighborhoods that are in that northern part of Macon as you drive into Macon. And then, of course, Savannah, which is a large portion outside of Savannah and the Savannah region, including down into Richmond Hill. We will also consider proposals that present compelling and viable models for special health-focused service areas within the PACE service areas previously discussed. Such proposals should really seek opportunities to present PACE models based on population values and characteristics that could offer better optimization and approach to the community-focused concepts of PACE. All special focus service area proposals have to include all the requirements that are in the RFP solicitation. So you can't get out of anything that is in the RFP solicitation. Financial viability analysis, a feasible study and business plan that supports this special health list of contiguous zip codes that the submitter intends to serve as part of the special health services focus area. A rationale for why you need to create this special health services focus area. What are the unique aspects of the population that would be addressed by the service, the special healthcare focus area, and a detailed explanation of how the organization will accommodate and support participants who enroll, but who do not identify as part of the special health services focus area. So if you got a certain focused area and group of people you're trying to work with, we need to have some sort of assurance that you can serve all people who want to join your PACE program. So now we're going to talk just briefly about the PACE implementation process. So for PACE organizations, you have to submit an application to CMS. It's not just the state. It has to include assurances from the state that the supplier is qualified and will enter into the agreement. And it has to describe your service region for PACE services. You have to construct a PACE center, right? Or convert a PACE center. It has to have a safe design. It has to have a primary care clinic, an activity center, transportation, dietary services, emergency preparedness, specialty care, therapy, and pharmacy ability. We have to go through the state readiness review. That's where the state goes out and determines the readiness of this PACE program to be in operation. There is a minimum set of criteria that is established by CMS for that. We have to be able to review policies and procedures, design and construction, and compliance with OSHA, FDA, state and local laws, including life safety code. And again, the PACE program has to enter into a three-way agreement between the PACE program, CMS, and the state administering agency, which is us. Once signed, the PACE organization can begin enrolling participants. So once you get through all these 4 steps, you can start enrolling participants. This is, again, the same thing, but with a little more information in a graphical format. We'll do a notice intent to apply, access to health plan management systems, the state application review, application for Part D for CMS. CMS may request additional information in that application that has to be clarified, which we typically in the business call an RAI. And then we do the state readiness review. At the same time, you might be responding to the responses to the RAI. And then CMS would issue an executed program agreement. At that point, your PACE center would open. And again, all this will be available like if you need to have like tick off information. So finally, we wanted to provide some resources, things that we go to all the time, like Centers for Medicare and Medicaid informations, the CFR that actually oversees PACE Center, which is kind of like our laws, what I always think of as our laws, and then long-term services information, and actually regulations from the PACE manual on guidance on how to get ready, things that will be done in the readiness review operations. At this point, we will pause for any questions we may have online or here in person. Have questions online. Do we? Oh, I should look. That's what I'm saying. There's a chat button. I can't really get to the chat button. No. Hold on, let me see if I can, because it says I'm sharing and it's a full screen thing. I don't want to.
One of the questions is the program beneficial for private pay agencies?
Is the program beneficial for private pay home care agencies? So it's just a program. I'm not really sure what that question, I might need more information on that question. I think from a state's perspective, we're just looking to award RFPs to PACE Center that we feel can meet the program designs as we've outlined in the presentation and in the RFP. So if you have another line of business and you are able to run a PACE center as well, then that would be okay with us. That wouldn't be an issue. We're just going to do a competitive process for the PACE centers.
So the next question we have is how many PACE organizations will be approved per region? So I can help with that. So we anticipate that of the regions presented, we would have one per region, except for the East Point College Park region. We anticipate there is enough volume there to initially award 2 regions. And then we would have to see upon implementation into the future if we need to come back and visit that for future award. But initially, we think that there's only sufficient population given the algorithm for 1 per region, except as I've stated in that other region, 2. And then a special focus region, they would have to demonstrate for themselves what's appropriate for whatever region it is that they're proposing in the number of zip codes.
The next question we have is, how many members can the average PACE center accommodate? Joe and I recently got to tour some PACE centers, and I think the largest one we saw had over 1,000, just over 1,000 members. They don't all come into the Adult Day Health Center every day. That would be like wild, right? 1,000 people coming in and leaving to the Adult Day Health Center. But they do deliver services to all them, and it varies. It varies by the center, and it varies by what that PACE center can accommodate. Do we have an estimate of when, let me get through these and then we'll get you guys' questions here. Do we have an estimate of when the RFP will be released? I'm going to go with soon. Do you have a better answer for that one? Soon? We hope soon. Perfect. Is that a good one? Thank you. We hope very soon. Are we following the same income guideline amounts under HCBS? That is yes. The answer to that question is yes.
Can a member be on another waiver and be PACE?
The answer to that is no. I like when I can do one-word answers. They're my favorite as a policy person.
When do you hope to have your first centers go live? And I'm going to say it all depends, because we really don't know until we receive applications and have an understanding of what's being proposed and where those providers are in regards to setting up a location, establishing renovations, and all the things. So it really is going to be organizational dependent once we review proposals.
And that kind of answers the next question about, does the timeline include approximate timing of RFP being released? Yeah, the timeline is all dependent on that RFP being released and being able to move forward with that.
What is the timing for additional PACE centers after the initial 6, and how will those areas be determined? So we have already worked with our partners at Myers and Stauffer to look at the next available population centers that have the most volume that could benefit from a PACE center. And we really hope to release those very soon after this release of this RFP and awarding, most likely in the quarter following the conclusion of this RFP. So that prospectively could be as early as the first quarter of 2025.
Will there be a cap on the number of enrollees per PACE organization?
So no, there will not be a cap on the enrollees. The thought is that you should be able to serve all the ones who would want to enroll in a PACE program in your region. And I think as Brian talked about, our experience is that you can expand and go from the center that he talked about that was 1,000. It started off with a much lower number, and then they expanded up, and they added auxiliary locations, is what I understood, to provide additional services or special services that may need to be available to accommodate that many people. But it's anticipated that we would be able to serve, up to 1,000, and we think that's probably most likely what the volume is at this point in time. And like I said, if we see that progresses beyond that and that there is demand, then we would revisit that in a future RFP.
So we have PACE program includes adult day care, correct? So yeah, PACE program includes everything. And I just want to say it again. The PACE program includes everything. Like there is no services that the PACE program doesn't provide. If you are an awarded PACE program, whether it's a home and community-based services, adult day health, whether it's a physician, pharmacy, that PACE center is required for delivering and paying for those services.
So let me skip to this. What happens if participants continue to use the emergency room instead of PACE centers for potentially avoidable visits? Or let's just say that they have hospital care and they become an inpatient. That is the provider's responsibility. Those costs are the provider's responsibility. Your interdisciplinary team and your interaction with that member is supposed to be to try and deter preventable visits that are there. But whatever that may be, all that cost of care is the provider's responsibility. So you may have, beyond hospital care, you may have other services that you don't directly provide that you have to contract for as a provider, particularly early on if you don't have dedicated services for certain things. Or there just may be specialty services that you have to contract for, such as dialysis or something along those lines, depending upon what your capabilities are. But to Brian's point, it is everything that that person needs from a medical perspective, from an adult day perspective. If you think about it as a nursing home, it is everything that a nursing home would provide, except they're living in their home.
So the next question is, we can participate in PACE and EDWP waiver simultaneously. I'm not sure who you are. If you're a member, the answer to that question is no. If you're a provider, the answer is yes, as long as there's not a conflict of interest. The next question is, and will Miller Trust be an option for over-income applicants? The same eligibility rules that we are currently utilizing for HCBS, we will be utilizing for PACE, and that would include our current provisions under the Miller Trust.
So the next one I see is adult day health the only applicable DCH license? And how long would a provider need to be licensed in order to apply for PACE? And let me clear this up. I'm sorry that if we've created some confusion here. We have referenced adult day as a service, and it is the services that are like an adult day. There is not a requirement in the state of Georgia that you have an adult day license to be a PACE provider. It's just that what you would typically see as an adult day license holder, those services are inclusively provided by PACE. But we're not licensing PACE. We made the decision that when we did the statutory permission to proceed or authorization, that we were not going to license it, that we were going to use the Medicare manual, and that we were going to do a three-way agreement, and that we were going to handle it through the CMS certification process in that manner. So there's no expectation that there will actually be a formal license. I know that in some other states, for some of the providers who are outside of Georgia, that there are licenses, and some have an adult day license in concert with PACE. It's just not the path that we chose here in Georgia. We tried to have the least amount of administrative burden to proceed and create a PACE program.
Thanks. The next question we have is, can PACE program groups outsource some services like OT? There were different PACE centers we saw that had vision people come in, had different specialties come in from an outsourced section. So there wouldn't be anything that prevented you from doing that. All the ones that we are familiar with do have their therapy in-house, but there's nothing that prevents you from it.
The next one we have is, for the region that will have 2 providers, will the service areas overlap? Yes, the service areas will be the same. It will be the exact same zip codes. I mean, it would be our hope, and we'll have to see who applies and what locations that they project to be located at, that perhaps we might have 2 providers that are geographically split in the region. That may not be the case. We have designed the region in concert with Myers that from anywhere in the region, you can have a PACE location. So they could be side by side and both serve throughout. It would just be the choice of the member to enroll in one or the other PACE programs. Or it could be potentially that there are two awarded to the same provider. It all depends upon the competition and what's provided to us to award that region.
The next question is, how long will applicants have to respond to the RFP? We typically do.
I'm a little hesitant to say because we haven't established the RFP. But you know, I think we'll give a reasonable amount of time with the thought that we do want to try and get it out and back quickly so that we can do an evaluation and assist the provider in moving on in the process. That is one of the reasons we decided to have a town hall and release all of this information in advance, define the regions, define the rates, to give everyone who has a true interest and is invested in their community and has locations or is prospectively doing that, opportunity to do all the advanced work, knowing that that RFP is, as my commissioner says for other things, imminent.
Yeah.
Soon,
imminent.
It's imminent to come. We hope very soon. So you should anticipate seeing it, and I would encourage you, if you're looking to apply, to do all the things that you would look for it if it were to come out tomorrow.
Eminent sounds more serious than soon, right? Can applying organizations be awarded to multiple regions? Yes, they could. Is there an approval process or network for IDT providers? Each individual interdisciplinary team would have to be developed by the PACE organization and meet our readiness review requirements. Will PACE be under the managed care companies coming to Georgia? No, PACE is outside of the CMOs. It's a fee-for-service design. How will PSS providers be chosen? That will be part of the PACE organizations to do. That's not a state responsibility. The PACE organizations would develop their PSS service package. That could be with in-house employees, or it could be somebody that they have chosen to do that.
I will say that will most likely be one of the factors that are evaluated in a competition to see, do you already have inroads, or you're already providing services or agreements with providers in the region that you're applying for, or do you already provide services with employees in that region? And the ones that have more experience, and particularly local experience, that's likely to be a factor.
Is participation in the PACE program optional for Medicaid participants? Yes, 100% member choice. Do we know how many days? We said imminent. So a lot of questions about when is the RFP coming out, y'all. Will the programs be required to have an adult day license? We already answered that one. Joe already answered that. Would the PACE program be responsible for open heart surgery? Yes, all services.
It would, and I'm going to reference this, that is likely we will address reinsurance in the application. And the reason that we would address reinsurance is for catastrophic events like this, that to make certain that providers have thought about large expenditures on a member that you may be responsible for. And open heart surgery is a great example because you'll be wholly responsible for that. And for those that are familiar, you can buy reinsurance at a fairly reasonable amount that would insure for large expenditures on individual members, so that would be covered.
Next question is similar. Are the contracted specialty services under the PACE program paid directly by PACE, or can you submit them outside of PACE? Nope. You're responsible for paying all services, so including the specialty services. We talked about outsourcing already. That was another question. Is there a PACE center we can visit to see how they are set up? They're not in this state, but there's one in Mobile. That's the closest one I know.
Yeah. And we talked about North Carolina, South Carolina. They're surrounding us. And Florida particularly has a number of PACE.
They're all around us. They're just not in this state. And you absolutely could set up to visit one of them. And the last question I think I have on here is, how does this affect personal care homes and assisted living facilities?
Well, I don't know that it directly impacts personal care homes and assisted living facilities, but I will say this. I think it is an opportunity for those who are living in an assisted care community or personal care home to stay within their living arrangement. So I've often had a question, well, we would like Medicaid services in assisted living. And there's really a lot of challenges to that in the state of Georgia. But if you did live in assisted living or in a personal care home and you wanted to enroll in PACE, you could do that as long as you maintained your residence and whatever the costs are for that independent. And then you would be enrolled in PACE for all the services since they're generally outpatient. And as long as that personal care home or assisted living community is in the region and within the transportation zone and all the things that would make them eligible. So I do think it's an opportunity for those living in those types of environments to enroll, whereas home community-based services is really a challenge for those licensure types to accommodate. This, I think, is a great opportunity for both of them to participate.
I know we got some questions inside as well. Let me go back over here first. Hold on. Yeah, you.
Me?
Yeah. Hey.
My question was, or at least maybe a little bit more clarification. I think when they're saying personal care homes, because I'm a waiver provider as well, they're thinking personal care homes that people are in based on your EDW waiver or even ICWP waiver. But they couldn't have that and do PACE.
Right. They can't be in both programs. They have to leave the waiver
Yeah.
in order to enroll in PACE.
Yeah, I think they were saying it's because if they're living in a personal care home, that waiver is what's paying for that personal care home. So how would they get it? I think that was what they were asking.
Yeah, that's an alternate living service. That's the name of that service. And it's not, so when we think about that in our world, that's part of a 1915C home and community-based waiver, and it's an alternate living service definition. So there would be nothing that could preclude somebody from saying, I don't want to receive services under a waiver. I want to no longer receive my services under the waiver and join PACE. It would probably be unlikely if they were an alternate living services service delivery model, because that's where they live, right? So they would have to, either make an arrangement with the alternate living service provider in order to pay their own way outside of the waiver, or they would have to continue to receive their services within the waiver.
Answering questions from the room. Can you repeat the question for the people online?
Yes, that's a good, so that question's answer was in response to that people were really thinking about home care, like assisted living care inside of the waivers, and how would that impact somebody who was in the waivers, and what would they have to think through? So I'll move forward and then I'll go back this way. Yeah.
Unless you've already been granted the RFP, right? We're not going to go buy a property unless we have the approval. Unless we have the approval via the RFP process. So I'm just a little confused on the fact that when you do the RFP process, obviously it is best, I am sure, that you have a site in mind, but you may not actually have a site at that point in time. And then the runway after approval to actually open a center can be months. It could be a long period of time, even if you've done your homework. So I'm just trying to wrap my head around that, because as an organization, we're looking at sites. We may have a site that we're focused on. We may not have purchased it and or signed a lease at the time of the RFP. So how do we rectify that kind of question about capital investment?
So there's sort of two different things. And there's a question that followed here, how much cash is needed? But let me say this, when we evaluate the RFP, and it'll be evident, we will take into consideration who is best situated to open and accommodate the enrollees as soon as possible. So some in Q&A and in research, some of the interested providers, they own a location that they plan on renovating, and they're they may be more readily able to open versus someone who may present, for example, a letter of intent to say, this is where I plan to open, and this is my letter of intent with the owner of that property. I guess at the very least, what I would expect is there is a letter of intent to say, this is where it's going to be, so that there can be a proper evaluation of the size. Does it meet the minimum size?
Sure.
Or is it greater than the minimum size in comparison to the competition, if there is any for that region, to do that? So it could be the whole spectrum, right? Or it could be that you show that you're going to close, as you're indicating, on a real estate transaction, if you're actually going to buy it, a letter of intent to purchase this facility or whatever the case may be to accommodate. That's really what we have in mind, that whole spectrum of we already own it, we're going to lease it, or here's my intent to buy it.
No, I appreciate that. That helps clarify.
I think you had a question? Yeah, just to make it easier to pass.
Yeah,
the
you
mic.
mentioned safeguards against conflict of interest. What does that look like?
We just want to make sure that there's not, it's really the same thing that exists in the home and community-based world, right? So we want to make sure that you don't have, just sole control over the member's choice, right? Like if a member can't choose to go to a home and community-based waiver, or the member only has the choice of one service provider in an area. Whenever we talk about conflict of interest, we want to make sure you're not pipelining people, that there's a choice for providers to have other service array and choices within the area.
Makes sense.
Hey, on the special help focus area, is that part of one of the 6 defined geographic areas, or could that be an entirely new geographic area, such as a rural area or somewhere else in the state?
It could be somewhere else. We said in what we put forward that you have to do your own study and demonstrate why that could be. So when looking at that, the thought process that I had is it could cross, for example, multiple areas that we're proposing at this time. I'll be honest, I was thinking that it would be, within or overlap multiple regions that we're proposing, but the way that we put it forward, it could be other areas within the state that are proposed, because it requires the applicant to demonstrate with a feasibility study that whatever that is and why ever that is, that it makes sense for that to be forward. So, but just keep in mind, it is going to have to be a particular special focus population. And so, for example, that might be a religious population that has special dietary needs that you would demonstrate, might be one example of what might be there. There could be many others that I know that we have some nursing homes that are of a particular, formed with a particular subset in mind, but you're going to have to demonstrate that there's enough population for that. And what we really are thinking there is that we would award a population that overlays that for the general population in addition to this. So keep that in mind. I don't know that we were clear about that, but our intent is that population is so specialized that they generally wouldn't go to the other PACE center within that same locality because of whatever their needs are. And I'll give a specific example of that. When Brian and I went to California, when we went and visited different PACE centers, there was a particular PACE center there, and they were predominantly for a religious portion that was in that region, and they were primarily Spanish speaking. They had a chapel. They had targeted for that particular population to do that. And we asked them, well, how many PACE centers are there? And they were like, well, we have like 4 in this region, but we're focused on this populations, and those are focused on different populations, and generally they don't mix, and that's why that's allowable. And that's what we're trying to accommodate.
Okay. Thank you. What is your question?
Well, Joe just mentioned the population, which is a segue for what I was going to ask. Is so the 1,000 participants, the sort of the target minimum target that makes this work.
Oh, no, that's not true at all. Thank you, Tom.
Yeah.
Is that the question I think Tom has is what is the minimum target that from a cash flow perspective
Correct.
would make this viable?
Yes.
So our understanding is that's going to vary depending upon the population you're serving and so forth. But in general, I've been told that you need to be around 200 participants at a center to be at a break-even point. Of course, you have to look at what all your costs are and what you project and how that would go. And I will say all the cash flow models that we have, and I've got another question that I didn't really address, that was what is the cash flow needs? And it really is dependent upon how many you're serving at any given time and how that goes. My understanding is you can expect that you might only have 2 or 3 enrollees a month as you're starting up. So it might take you 2 years to get to a break-even point. So you really have to think about your capital needs. And when we look at applications, we're going to look that you're properly financed with credit or with a parent entity that has sufficient cash flow to carry you at really a loss for the first couple of years until you can enroll past that break-even point of 200. And the 1,000 is really more of a cap. I mean, we had the ones that we visited, they had anywhere from 300 to 350 to 400. And then that was really an anomaly up to 1,000. They had been there the longest and had the most inroads to the community.
And we were at an association meeting, so that was true of every state we talked to when we were in, not just the ones we visited, when we engaged people from other states as well. Very common story about that. Well, you got to be near 200 before you start to break even, and that it's a slow climb to get to that 200. Yeah.
Will program participants be required to work through a third party like a AAA to determine eligibility, or will the pay site be able to determine eligibility and get them signed up themselves?
Well, we'll have a requirement to, like with everything else, to verify level of care, but we don't anticipate like a third party. It's likely that we will utilize our existing external review organization to review that level of care determination.
Okay, thank you.
Just like we do with the waivers, though. Yeah. Thank you for being the microphone person for a minute. We appreciate that. I have a bad
Joe,
day.
you mentioned something about a feasibility study, and just wondering if that is going to be spelled out in the RFP. What is going to be part of that feasibility study?
I don't know that we will provide a lot of detail, to be honest, in that we really added that special focus area to accommodate someone to bring that forward. The thought being that, well, I'll be honest, Brian did the evaluation of the grants, and I think there were some, and there were some providers that applied for grants that already had feasibility studies within their grant applications. And it really gave us the thought process that, well, they can evaluate their own, and we'll just have to evaluate that and see if it looks viable. I will tell you most likely what we would do is have Myers overlay whatever is presented to make sure that it's viable with the algorithms for the zip codes and makes sense with how we've awarded other districts for the special focus population.
So if I could just follow it up, because that was kind of a question to lead into what our next question was, which is, so as part of the feasibility, if I heard you correctly, the special focus centers, we have to give you a compelling reason why one would be. You're not going to clearly define that. We have to define that. And I'm going to use us as an example. As a Jewish organization, most of our buildings are kosher. So if we're in an area where, let's say there's a Jewish population that we can capture, and so we decide to have a kosher facility, we need to basically, in the feasibility study, explain to you why we think this should be a special focus area.
That's right.
Okay.
So for example, you might, as an organization, have an assisted living community, have a personal care home, have independent living, all within a Jewish community. I think that happens to be the case for your situation. Others may have similar situations. So you might be able to demonstrate, hey, I'm already have a continuum of care already all the way to the nursing home. Here's my population. Here's how I'm demonstrating that.
Great, I appreciate that.
Joe, you mentioned that the rates will get updated annually, and we hope that there won't be a high utilization of nursing home beds. However, will those rates get pegged or adjusted annually with a look back when the SNF rates go up or down? Up, hopefully. So will there be some consideration for that?
Yes, so the way that the actuary does their rate compilation, having lived with that with the CMOs, is they will look at historical claims cost for those populations, and they will do the most recent claims cost that they have in order to do the new rate. So for example, right now, for the CMO population, we're preparing for our upcoming 2026 rates in July of 2025, and they have stated to the CMOs, we're going to use the 23 claims data that we have. And the reason for that is they want to get all the run out, and it takes a whole year for those claims, almost a whole year, for them to get all the claims that were in 2023, but were paid at a later time. So generally, that's what they're going to do, and they would do the same process here. So as we advance and they establish and look at that rate, they would do that. And then that would also accommodate other things that occur, such as new pharmaceutical products that are available, the cost of that, if that's in the population. We're dealing with that right now and looking at the sickle cell gene therapies that are available and how that might impact rates and so forth. So anything like that would be accomplished. And we not only do we look back, we also look prospectively at recent data that we have, the actuary does, the most recent data they have in claims, to make sure that if there's anything that did occur just recently, that they accommodate that to the extent that they can actuarially include.
Well, thank you, because we were talking to the PACE Rhode Island executive director, and the state adjusts that rate every 3 years, which is harsh for the PACE organizations because a lot can happen within 3 year span. And so they have to kind of deal with those rate pegging later on. It becomes challenging. Thank you.
I had another question which was pointed out to me online. It says, suppose an individual chooses to leave the PACE program, at what point is the PACE program no longer liable for health care costs for that individual? And my understanding is it's whenever the enrollment eligibility date officially ends and they are out of that program. So that would be a person's choice if they chose to leave. And then it would be whenever we quit paying the PMPM to that individual. So you might, just as an example of what we were just saying, you know, that person may leave, but then you may get a medical bill for that person that occurred when they were enrolled. You're still responsible for that medical bill as long as that service was through the period that you were paid a PMP, per member per month amount.
It's not unlike a hospice lock-in, right? Hospice lock-in's the same way. Other questions?
So to be a PACE provider, you must operate at the PACE center. Well, yes.
Yes.
I mean,
That's an easy one, yes.
Some PACE grant awards include proposed PACE sites outside of these service area zip codes. Are those grant awardees restricted to the service areas shown today, or are there other zip codes available to them?
So that's a good question. The grant that we've talked about is not directly related to the RFP. They're different things. It was meant for capacity building for the 3 nonprofits that were chosen, but those 3 nonprofits are not awarded a service area. They have to go through the same RFP as anyone else. They're really separate things.
Essentially, individuals participating in PACE pay for their housing privately, and all other medical and living expenses must be covered by PACE. That's essentially true. I don't know that all living expenses are covered by PACE. For example, I mean, the traditional things that you have with an apartment are going to be your responsibility, such as, you know, cleaning and cable and heat and air and all the things, and liability insurance, all the things that are covered for a living arrangement, need to be covered. But yes, from a medical standpoint, it does include that, and as we referenced, adult day services, which are traditionally meals. So home delivered meals, or making sure that they're cared for in that manner and that they're eating effectively, so that when the IDT team assesses them on a periodic basis, that all of their medical and dietary needs are met.
Correct. I mean, some of the PACE centers have some non-traditional services they provide, and it's up to them. You may have like a hair salon in one or something like that we typically don't pay for fee for service, but the services they provide are medical services. They're like not going to pay for you to go visit your daughter in Florida, nor are they going to pay for your, cable bill. That's not something they do.
Are potential PACE organizations required to use a PACE consultant as they develop their program?
No, it's up to you. If it's best for you to have a PACE consultant to develop your RFP and do readiness, or however you do that, we're just doing a competitive bid process.
Okay, the other one that I see is, do you have an estimated fiscal reserve requirement yet? And when we come out with the RFP, we will address that. But I will say that, we've already talked about that a little bit. You've got to be well financed in order to demonstrate that you're going to be able to operate at a loss for the first 2 years, and also demonstrate to, as we talked about before, what facility are you going to use? How are those costs covered? Do you own it? Are you going to lease it? Or are you going to, buy it and renovate it? How's that all going to be done? So it's really incumbent upon the provider to demonstrate that they thought about what is their financial plan and business model to be financially viable, and demonstrate that they have enough money on hand or credit to accomplish the implementation and the development of that to run for at least 2 years, most likely, until such time as they become at a break even.
Yeah.
So the state of Georgia will not add, or is not considering adding, additional reserve requirements, because there is already a CMS requirement of having 1 month's capitated revenue in reserve. I know that there are states that require additional reserves, but that will be spelled out in the RFP, I hope. But right now, that's not a consideration because that's material.
I would ask you to wait for the RFP because we will have our specific guidance in there, but you can be assured that any CMS requirement will be the minimum.
Yeah. Just making sure we don't have any other questions.
Will contracted providers like ALS or PSS be required to pay waiver rates?
So it's best for you not to think of the waivers and PACE as somehow connected. So the waiver rates are the waiver rates that are in waivers for people who have elected to be in those EDWP, ICWP, now, or comp, right? Those are rates that are specific to those waivers. These are different organizations that will be responsible for hiring and paying the staff or their contracted entities to deliver the services for PACE centers. They're not connected in any way. It's not like the PACE centers will have to pay PSS providers the rate that is in the EDWP waiver. I get where your head's going, but that's not the way it works. They're separate programs.
I believe we've addressed all the questions. However, I will say that there is a provision that you can ask questions and we would respond holistically. We don't do individual one-off questions because from a competitive standpoint, we want everyone to have the same information. So if you do have a question that we have not covered here today, you can email our point of contact on the website, and we will answer that question accordingly and post the answer on the website so that everyone has that opportunity to review it.
Let me say something. Hello, everyone. My name is Azia Hirome, and I'm the Deputy Director for Office of Procurement for DSCH. And so the RFP will be coming through me. If you have any questions, like Joe said, please, email the email that was in the notice. And also, I wanted to state that you should register right now on the Georgia Procurement Registry. I believe I stated that to some of y'all. And the NIGP codes that will be listed in RFP, which will notify you when it's posted on the registry, where on that notice at the bottom. So when you register, if you have not already registered on Georgia Procurement Registry, please use those NIGP codes so that when it is posted, you'll be notified and you can respond. Does anyone have any questions for me? Okay, thank you.
So I think we just want to thank everyone for coming, and thanks for all your participation today. The questions were great and really help us to get out a lot of good information. Again, thank you for coming, and have a great weekend.
Thank you.